to be involved in the PHM work in Coventry, and essentially it's targeting healthcare towards people affected by health inequality, looking at social determinants of health, and really using a different approach to healthcare. So using a data-driven approach to identify populations who are affected by long-term conditions, for example, and using that data to identify patients who might benefit from individualised, personalised approaches to management. For clinicians, it's been really interesting in that they've identified a whole new way of working, and there's multiple strands to that. So actually being kind of proactive in terms of case finding our patients that we'll talk about in the programme, but essentially having a different way of working and identifying those patients most at need within our communities, and then working closely in partnership with primary care, but all the additional roles in primary care such as social prescribers. Longer term we envisage working with local authority, particularly leisure service providers and so on. So we're working more as an integrated team to identify the population that are affected by a particular health condition to then hopefully improve their long-term outcome.
Locally, I've been part of the population health management programme where we identified a cohort of patients with chronic low back pain, and the criteria were patients with chronic low back pain who used or were prescribed opiate medication, anything ranging from low dose codeine kind of upwards. They were of working age, so 18 to 64, and they had a diagnosis of obesity. And we used the data to identify these patients and look at the wider determinants of their health in terms of socioeconomic status, GP appointments, emergency attendances as well. So the point of the population health management programme is to design a service which we've done in conjunction with physiotherapists, and we ran a pilot programme where we invited these patients to meet with a physiotherapist, where they had an extended appointment, a 45-minute appointment, and so yes, we haven't followed these patients up long term, but certainly the patients that were seen already, even in the early days, benefited from that intervention in terms of lower prescriptions of opioid use, and we think that probably long term that will probably lead to less secondary care referrals, less GP appointments, and also the wider socioeconomic impacts in terms of often people with chronic low back pain are off work long term or not in work as well. The exciting thing about PHM and implementing it is you can design a local solution to a local problem. And so at your practice or your PCN, you can identify a cohort of patients which you have already identified or already suspect are not being managed very well. And the list of possibilities are endless, for example, but you could, for example, pick a health condition like diabetes, and you could identify your patients who have poorly controlled type 2 diabetes, and you can look at why that particular group of patients aren't managing very well, basically. So yes, it takes a bit of work initially, but actually the outcomes for that would actually lead to less time taken for the GP in terms of it would almost certainly reduce appointments. And also we bring in allied health professionals in terms of dietitians, social prescribers, relative to that health need.